Disc 2 concludes with a discussion Sidney Smith had with Dr. Jurien Berg, an interventional cardiologist at the St. Antonius Hospital in Nieuwegein, Netherlands, to discuss WOEST, optimal therapy after coronary stenting in patients requiring oral anticoagulation.
Welcome to ACCEL.
Thank you for the invitation.
This trial addresses an area that I think most cardiologists, and especially those involved in interventional cardiology, have a great interest, and that is triple therapy versus double therapy. Where's the evidence? And now from you, I think we have one of the first, if not the first trial to really randomize patients and try to find out where we stand in this approach. Can you tell us a little bit about the design of your trial?
Maybe first give you the background of the trial. As you said, it's a very interesting field because we do not know what the optimal antiplatelet therapy is in these patients. And what we do know is that they need Coumadin. And after stenting, there's also a need for aspirin and clopidogrel. However, as you say, triple therapy is also risky because it leads to more bleeding. And we know that bleeding is related to mortality. So the hypothesis of our trial is that leaving out aspirin and treating the patients with double therapy, so only Coumadin and clopidogrel, would reduce bleedings, but at the same time would not increase the thrombotic risk of the patients. So what we did, it was a randomized trial, randomizing patients who were on Coumadin already for AFib or mechanical heart valves to triple therapy, Coumadin, clopidogrel and aspirin, or double therapy, and that's Coumadin and clopidogrel alone. And we followed those patients for a year after stenting, and the minimal duration of treatment with clopidogrel was 1 month after bare metal stenting and a year after drug-eluting stenting.
And the dose was 75 milligrams, I'm assuming, of clopidogrel.
The usual dose of 75 milligrams.
Low-dose aspirin.
Low-dose aspirin.
And what
patients.
about the INR for the Coumadin? How was that maintained?
That was the similar INR for the indication for which the patients were treated with Coumadin. So usually for AFib between 2 and 3, and mechanical heart valves, say the newer valves between 2 and 3, and sometimes between 2.5 and 3.5.
What was the breakdown between mechanical valve and atrial fib?
Most of the patients had AFib, so it's 75% of the patients who had AFib. It's about 10% mechanical heart valves, and the others are, for instance, patients with severely diminished left ventricular function, below 30% ejection fraction, or other reasons.
The INR in both groups similar? Was there any difference in INR?
We don't have all the data on INR during the follow-up. We have the data at the time of the PCI, which was similar, was 1.9 in both groups. But we have to obtain all the INR values over time.
What did you find?
There was a striking difference in the occurrence of bleeding. So the primary endpoint of this study was TIMI bleeding in the first year, which was 44.9% in the triple group and 19.5% in the double group. So a huge difference in favor of the double group.
That's remarkable. And so it's going to be very important to know the INR. And I would assume the bleeding is most GI rather than a CNS bleed or other.
Yeah, absolutely. So intracranial bleeds was similar and very low in this study. And the difference was especially in procedural bleedings and gastrointestinal bleedings, as well as hematoma, skin bleedings.
I guess the INR, until we know in the group that had more bleeds whether or not the INR was higher, that's going to be an important...
It will be important. I have to be honest about it. We do not have the INR values during follow-up yet. So we have to look into that.
With the bleeds, were they similar in terms of severity? We're talking about major bleeds. Are we comparing?
Major bleeds. So, for instance, TIMI major bleeds was numerically lower in the double group. So there was a 50% reduction, but that didn't reach statistical significance. So the major difference was in TIMI minor and TIMI minimal bleeds. Those were statistically significantly different.
Quite interesting. You know, the guideline committees have wrestled with this because there are no data or minimal data, and most of the recommendations in this area are level of evidence C in the ACC-AHA guidelines, that is expert opinion. And in general, favor maintaining a low INR. You started at 1.9, we say 2 to 2.5, so you can't say that the INR was really high, at least when you started. Mm-hmm. And it certainly appears here that double therapy is as efficacious in terms of events with much less bleeding than seen with triple therapy. Is this changing your practice, or have you?
It is. I have to add that the secondary endpoint, which was efficacy endpoint, thrombotic risk, was also lower in the double group. That was unexpected. So we saw a lower incidence of stent thrombosis, a lower incidence of myocardial infarction, and even a significant lower incidence of death. So it seems to be safe, and at the same time leads to less bleeds.
So stent thrombosis, myocardial infarction, and death. What about embolic events related to the valve or the atrial fibrillation? Were those similar?
Stroke was also, that's the one we counted in this study. Stroke was also numerically lower in the double group.
Well, I have to compliment you on taking this on, because I think it's an area where most of us feel we need evidence, and these are impressive data. The total number of patients in your study and age, we probably ought to describe that for the ACCEL audience. How many?
So total number is 573. The age was 70 in both groups, mostly male. And it's quite a high-risk population. So many patients had diabetes. A quarter of the patients had diabetes. For instance, 17.7% had prior stroke. So it is a high-risk population, I guess.
Well, again, congratulations, Dr. Berg, on an excellent study, and I'm sure we'll see this published very soon. This is quite interesting, and I think potentially very helpful to patient care.
Thank you.
And that brings us to the end of Disc 2. For details about studies discussed, refer to the written summary that is included as a PDF file on Disc 3, which begins with a discussion of HDL particle concentration is a more powerful risk predictor than total HDL cholesterol.